Good evening, everyone, and welcome to another one of our Zoom sessions. And this is going to be the first session of this year, and it's been a while. I've been kind of busy, and most of us who do this session have been kind of busy, so there's been a bit of a gap this time around, but hopefully we'll be able to continue in somewhat of a regular fashion after this. Today's topic is going to be on hypoglycemia in cardiopulmonary resuscitation, and this is a topic that is frankly not very well discussed in any textbook. And once you actually go into the literature a little bit, you'll see that it is a very convoluted topic and very difficult to actually find conclusive answers to this. So, to start with, we'll just give you a case scenario. So we have a 58-year-old gentleman here. He's having multiple comorbidities, diabetes, hypertension, chronic kidney disease. He's presenting with complaints of autosensorium, short of breath, is visibly tachypneic. On arrival, is altered. His RVS is 40. And and while your staff is actually preparing your dextrose boluses and infusions, patient becomes completely unresponsive and absent carotid pulses, and you start CPR. Now, the question here is, in this particular scenario, would you give IV dextrose or not? So if you think you should give IV dextrose, just give a yes or a thumbs up in the chat box. If you don't think you should give IV dextrose, you just say no in the chat box. Just see what the responses are for this. So should we give dextrose or should we not? One person saying yes. No. Okay, so somebody saying no. Okay, so most people saying yes, one person saying no. So how are we going to do this talk? Basically, we are going to go into three basic topics here. So one is going to be around the controversy surrounding hypoglycemia and cardiac arrest. Second thing we'll discuss is the optimum blood glucose levels that you have to target post ROC. And finally, and the simplest part that we all must be somewhat familiar with is the management of hypoglycemia. So suppose you we are going to attempt to answer some of these questions. So one is whether hypoglycemia can cause cardiac arrest, whether we should be checking for hypoglycemia during cardiac arrest, whether we should go one step further than that and consider empirically giving dextrose to everyone who present in cardiac arrest, and what is the optimum blood glucose levels post ROSC. So what is the problem here? So the problem here is that initially it used to be part of the 5Hs and 5Ts. So hypoglycemia used to be a part of the 5Hs and 5Ts way back in 2005, before 2005 actually, before it was removed. And it was actually never included in the European resuscitation guidelines for managing cardiac arrest. But the problem is that even though it was removed way back then, if you look at the AHA registry data that I get with the guidelines registry database, so it actually says that in hospital cardiac arrest patients, the use of dextrose actually increased during that time from 2001 to 2016, despite these guidelines specifically saying that you should not be giving IV dextrose in cardiac arrest, and that hypoglycemia is not one of the five H's that you should be thinking of. So there is a mismatch between what the guidelines say and what physicians are actually practicing. So why is that? So let's imagine you have a junior here, and he is very adamant, like some of you, that we should not be giving dextrose in patients with cardiac arrest. And it gives you not one, not two, but five reasons why we should not be giving dextrose in patients with cardiac arrest. Number one, he says, not in the guidelines. Not in the guidelines, I'm not going to give it. Fair enough. Number two, he says that capillary blood glucose levels are unreliable in patients with stroke. and as an extent in patients with cardiac arrest. So why even bother? Third, he says that look, heart uses acid oxidation for energy purpose, not glycolysis. So why are we even bothered about dextrose when patient is having cardiac arrest? Number four, he says that well, there is no good evidence that hypoglycemia can cause cardiac arrest. And finally, he says that hyperglycemia post ROSC has been shown to be associated with worsened neurological outcomes. So he gives you these reasons, not one, not two, but these five reasons why we should not be giving dextrose in cardiac arrest, and we'll try to discuss each one of these points one by one. Number one, it's not in the guidelines. Definitely, it is not in the guidance at all. Agreed. But it is not in the adult guidelines for cardiac arrest. It is included in PALS. So when it comes to PALS, it is included in the five H's in PALS, or rather the six H's. So if a 12-year-old comes with cardiac arrest, you will consider hypoglycemia as one of the causes. But if you have a 14-year-old coming with cardiac arrest, you will not consider hypoglycemia as one of the causes, which is kind of absurd. So maybe we should not be following all the guidelines very, very strictly like that. And we should actually go into the evidence a little bit to actually draw some better conclusions. Number two was that finger stick glucose values are not reliable in patients with shock. And this is definitely true. So, if as per the studies, on average, there are about 67% of your venous blood glucose value. So, if you're looking at capillary glucose versus venous blood glucose, what is more reliable is going to be your venous blood glucose levels. So, and the difference is going to be varying whether the patient is normotensive or whether the patient is hypotensive. So if the patient is normotensive, it will be less by the capillary levels will be less by around 12. Whereas in hypotensive, it will be three times lower than that. It can be lesser by around 35. So which is a pretty big difference. But there are also some caveats here that we have to be aware of. One thing is that uh, just because some value is low, even if it is finger stick glucose, it can still be real depending on the severity. For example, if the patient's blood glucose levels is like 20, so even if you have 34 to that, it's still 54, and that is like level 2 hypoglycemia as per the guidelines. So that is still pretty bad, and that's not something that you would like to actually, you just ignore like that. So that is one thing. So just because it is all of these things exist in a range. It's not like some magical science that you add 30 to all of these things. It exists in a range. So it's something that is low might still be low, of course, even once you check the venous blood values. And another thing, not every erroneous value necessarily needs to be in the same direction. Could be that it is actually a little bit higher than the actual venous blood glucose values. That can also rarely happen. So we should, if you only have these finger glucose values available to you where you work immediately, so that may not be something that you should necessarily be ignoring completely. So next thing is heart runs on fatty acid oxidation. Completely true. That is definitely true. But the thing is, there are again some caveats. So Lopuchuk in 2021 showed that in patients who are having heart failure, they will start to have a higher reliance on glycolysis. So it is not a one and done thing. It's not a fixed thing. So in patients with having underlying heart problems, they might have a higher reliance on glycolysis for energy purposes. So another thing is that one thing, the peri-arrest state can have a high adrenergic surge in a lot of patients, and we are giving exogenous adrenaline cardiac arrest as well. These can actually deplete your glucose and glycogen stores as well. So these are another physiological reasons, rationales why we should not dismiss the possibility of dextrose being useful in cardiac arrest patients. Other than that, you have to also obviously keep in mind that the heart is not the only organ that we are worried about in a patient with cardiac arrest. The most important thing that we want post ROC is having a good neurological outcome. So hypoglycemic encephalopathy is a very, very thing to have. So basically, patient will have persistent neurological persistent poor GCS even despite normalization of your blood glucose values, and can have very poor outcomes because of that. So in keeping that in mind, ignoring low glucose values is again probably not a good sign. So finally, so not finally, so penultimately, so hypoglycemia doesn't cause cardiac arrest. Now we are going into something that is going to be a bit controversial. So there are some case series published where hypoglycemia might have been the main culprit in cardiac arrest. So there is something called death in bed syndrome. It was based on a case series published in 1991 on patients with type 1 diabetes, and these patients had hypoglycemia during they had deaths while they were sleeping, and they were otherwise completely healthy before going to bed. So it is estimated that it is hypothesized that this was something related to hypoglycemia, and type 1 diabetics are going to be having multiple episodes of hypoglycemia regularly. So there are multiple animal studies, most of them done by this Reno group here, on what hypoglycemia can do in rats, basically. So they have shown that they induced type 1 diabetes in this rat, and show that severe hypoglycemia induced fatal cardiac arrhythmias. So there is something here with especially in this population of type 1 diabetes, where that is predisposing them to fatal arrhythmias. The initial finding is actually a QTC prolongation. So the initial finding is QTC prolongation, but what is interesting here is that even though the finding is QTC prolongation, it doesn't automatically result in polymorphic VTAC, which is what we would be expecting. So as you get into more and more severe cases, you have bradyarrhythmias as well. So you're having various types of AV blocks as well. So what is going on here? So there's postulated that there is some difference in awake patients and asleep patients in with regards to hypoglycemia. In awake patients, more risk of VTAC. Sleep patients, more risk of high-grade AV blocks. So why does this happen? So it is postulated that hypoglycemia causes some kind of disbalance between your sympathetic and a parasympathetic system, and this can either result in tachyarrhythmias or result in bradyarrhythmias, depending on what the dysregulation actually ends up doing. So that is a hypothesis. For other studies that they did show that there are basically two ways where hypoglycemia can kill. One is arrhythmias, which you have already mentioned, leading to cardiac arrest. Two is seizure. So hypoglycemia leading to seizure can lead to respiratory failure and cardiac arrest, which is not surprising. So interestingly, what they showed that in rat models, obviously this is not something to be done in any patient that you actually see, but it's just something interesting that they found out, was that by giving levetiracetam and beta blockers, they were actually able to reduce mortality in this rat population. So levetiracetam alone or beta blocker alone, not as good as using both in combination. So again, this is what they hypothesized, that there are two basic pathways leading to death here, and by treating them, the sympathetic dysregulation, autonomic instability, you treated with a beta blocker, and your seizure risk you treated with anti and epileptic. So that helped to actually reduce the mortality in rats, not in humans. But again, in humans, we have case reports where the only culprit that people were able to find for the patient going into cardiac arrest was hypoglycemia. And in my career also, I have seen one or two cases where I was also not able to find any other cause for patient going into cardiac arrest other than hypoglycemia. And in one case, patient actually had a very dramatic improvement after giving a drug dose, and patient got extubated, and I had a good outcome also. And the only thing that we could find was actually hypoglycemia. So not common, Not something that you're going to see every week or something, but it is something that is possible and something that you might want to consider, especially in a patient with type 1 diabetes, and you're not able to, really find out anything else. The final point that was made was hyperglycemia is associated with poorer outcomes post ROC. Completely true. So there is a review by Pang et al. In 2015 show that in hospital cardiac arrest, receiving Dextrose worsen neurological outcome, decreased survival. Very true. But the opposite is also true. Wang et al. In 2019 showed that patients with the blood glucose levels of less than 150 actually had worse neurological outcomes. Interestingly, there have been studies where there appears to be a Goldilocks middle ground where if you where blood glucose levels of less than 70 are associated with worse outcomes, more than 180 associated with worse outcomes, and but somewhere in between you have more chances of a sustained ROSC. So this is again interesting. So what we might take out from this is that very low blood glucose and very high blood glucose might be bad in the post ROC scene. But again, this data on hyperglycemia being bad, that doesn't necessarily mean that hypoglycemia is okay. So at least we can you can take that much away from this. So finally, what does AHA said? So because of the convoluted nature of this data, they are not going to give you any specific guidelines of exactly what to do and what not to do. So no specific guidelines on hypoglycemia. Post ROC, however, they recommend that you should avoid both hypoglycemia less than 70 and hyperglycemia more than 180. So they recommend that you avoid both of these things and try to maintain something in a safe range in between these two. So now we are going to transition little bit towards post ROSC and maintaining optimum blood glucose levels. And the question you have is where does this optimum glucose cutoffs actually come from? So you have to understand that glycemic control and in the critically ill, it is going to be a little bit different based on whether the patient is a diabetic patient or whether the patient is a non-diabetic patient. In a patient who did not have diabetes before they presented to your hospital, increased blood glucose levels, increased glucose variability is associated with increased mortality. So that is not good. Whereas in a patient with diabetes, increased blood glucose by itself, it is not going to be associated with increased mortality, obviously. So logically single patient is already living with increased blood glucose daily. So just because patient is having about increased blood glucose on an already known case of diabetes, that is not going to increase mortality by itself. But in these patients, hypoglycemia will increase mortality. So this is a basic idea that you need to have. Going into the literature that we have already discussed this in detail on another lecture we had, which is on inflation glucose manager, but we'll briefly go through the literature here. So the main trials that we have five main trials on this, which is the Leuven surgical trial, the Leuven medical trial, the BICEP trial, the NICE sugar trial, and the TGC fast trial. So these five trials over the last 25 years or so are what we base all of this management on. So initially we had the Leuven surgical trial in 2001. So basically they looked at tight versus more of conventional glucose control in surgical ICU patients. And they found that it actually reduced mortality, the tighter glucose control. So based on this, a lot of enthusiasm came that you should be having stricter glucose control, 80 to 110 times. You have to maintain that in our critically ill patients. And that is how it was done for a little while. But the thing is that this trial had some weaknesses. It was single center, unblinded trial. Most of the patients were like post cardiac surgery patients. And the fragility index was not great. So it is like two only. So only two of the patients in the trial had a different outcome. The entire overall result would change from positive to negative. So the same group, the Leuven surgical trial group, they decided to repeat the trial in 2006 on medical patients, and it did not show any benefit. So in medical ICU patients, they were not able to replicate the study results. Then we had another trial, the BICEP trial, and which is an RCT on around 500 patients in Germany on sepsis patients. Again, this actually showed increased mortality with the more tighter control group, and which was actually stopped early due to harm. Then we have the landmark trial, which is a nice sugar trial, which is what we actually base most of our guidelines on as of now. We choose a large multi-center RCT in multiple continents, actually Australia, New Zealand, and North America. 6,000 patients, huge number of patients, and they compared diet control, which is around 80 to 100, which more conventional control, 140 to 180. And they actually show that there was increased mortality at 90 days with tighter control. So around 3% increased mortality after with the tighter control. After this, we had a TGC fast trial, which is again very even larger RCT than nice sugar type, 9,000 patients. Again, comparing 80 to 110 group versus a more liberal target of 180 to 215. This showed no differences in mortality. So what we can basically understand from this is that we're going from 2001 to the 2023, the cutoffs for safe limit of hyperglycemia has been slowly increasing, because what we have shown is that hypoglycemia increases mortality and we have to avoid that as much as possible. So the cutoffs, safe cutoffs have been slowly increasing from 110 to 180, and latest it can be up to 215 also. Now, does this mean that higher cutoffs are unsafe? No. It's just that higher cutoffs are not actually studied yet in any of these trials. It could be that in the coming year somebody will do another trial using a higher cutoff for blood glucose than this, and that will also be shown to be safe and will again increase this cutoffs more than this. But for now, we have various guidelines. Most of them are going to be based on this. American College of Physicians 2014, you target something around 140 to 180 in ICU patients. Society of Critical Care Medicine 2024, 140 to 200. ADA guidelines 140 to 180, but up to 250 might be acceptable if the patient is having high risk of hypoglycemia, like your CKD patients. So what are the risk factors for hypoglycemia? Elderly patients, CKD patients, having history of hypoglycemia in the past, type 1 diabetes, they have very frequently have hypoglycemia, and patient did not have a history of diabetes before they came to the hospital, or their HbA1c levels are not that high to begin with. These are the patients in whom you have to be very careful. CKD, CLD patient, these are high risk because these are the organs where you have gluconeogenesis, and once they are gone, then it will the patients become at higher risk of hypoglycemia. CKD patients, again, you are not excreting out in insulin as much if your kidneys are damaged, so it will stay in the body longer. So again, higher risk of hypoglycemia. So these are things that you should always take into consideration when you are trying to optimize the blood glucose levels for any patient in the emergency or the ICU. So I hope all of this made sense. Finally, we have the management of hypoglycemia. So how do you basically manage hypoglycemia? So we basically try to give 25 grams of dextrose. You give either 25% dextrose 100 ml or 50% dextrose 50 ml. Either of these will give the patient around 25 grams of dextrose, and 25 grams of dextrose will increase your blood sugar level by around 100. Then you start a patient on a maintenance dextrose containing IV fluid until they're able to take orally. Their sensorium is improved enough to take orally. Then you can transition them off that. And obviously, then you'll have to evaluate for why the patient became hypoglycemic. So if they took their insulin and didn't eat food, the cause is obvious. But if the patient is having some other issues, you have to evaluate that. Look for sepsis, look for nuanced renal failure, liver failure, etc., and consider all of those causes as the possible reason why the patient went into hypoglycemia. In peds, it's going to be 10% dextrose, 2 ml per kg, followed by glucose infusion rate of 5 to 6 mg per kg per minute. So some people will have a question whether whether we should we should use 25% dextrose or 50% dextrose in your adult patients. If you only have 50% dextrose uh, available with you, use it. So you should not let the patient have hypoglycemia like that and damage their neurons. Whatever you have available, you just use it. If you have using the higher concentration, make sure that you have a good cannula. So because thrombophlebitis and soft tissue reactions can occur if you have a very flimsy cannula in place. There is a concept where having lower concentrations of the dextrose infusions will and using lower concentration will reduce the risk of recurrent hypoglycemia. So it will having lower using a lower concentration like 25% dextrose or even lower than maybe 10% dextrose using an infusion like that will reduce the risk of recurrent hypoglycemia. That is a consideration that you can take if you have multiple options at your place. If you're working in a peripheral setup where this is the only thing that you have available, definitely you use whatever you have available. Other things that you can consider: glucagon, not a very good choice. Why? Because glucagon can cause vomiting. And how do these patients generally present? With outer sensorium. Outer sensorium and vomiting, they can aspirate and it becomes a huge problem and they can die because of that. So not a very great option. Sulfonyl urea exposure can be very bad because the glimepiride and all, they can have a long duration of action and they'll have recurrent hypoglycemia. So you can consider things like octreotide in those kinds of patients. And if the patient is still going into recurrent hypoglycemia, then you can start thinking of maybe adding a bit of steroids as well. So going back to the question that we had at the start of the lecture, can hypoglycemia cause cardiac arrest? Maybe, but at the very least, we can say that there is nothing that has been shown to make you think that hypoglycemia cannot cause cardiac arrest. So there are some animal data, some case series, some case reports, all of them showing that this is a possibility, and especially in type 1 diabetes, this is something that you should be keeping in mind. Should we be checking for and correcting hypoglycemia in cardiac arrest? Probably yes. Based on the evidence that we have, it is mostly a safe thing to do, and we're not going to be causing harm in most of the patients from a little bit of dextrose. So it's an easy thing to check for, and it's an easy thing to correct if you find it out. So the, there is nothing wrong in checking for and correcting hypoglycemia. Should discuss be given routinely in all cardiac arrest? No. So because hyperglycemia has been shown to be having a poorer outcome. So because without looking at the glucose levels, blindly giving the is probably not a good idea. What is our optimal glucose levels post ROSC? Not really sure. So, as per AHA, avoid hypoglycemia less than 70, avoid hyperglycemia more than 180. But what is the actual optimal level? It is something that is up for debate. But we should be at a safe level where patient is not going to be at risk of significant hypoglycemia. So that is all for this talk. It's a very small topic, but it is a topic that we have not really covered in most of the textbook or even the usual BLS ACL classes as well. So I thought it would be interesting if you discuss that today. So I hope this was useful, and thank